In our practice, we often see that snapping scapula syndrome could be related to one or maybe a couple of several different reasons. One is a shoulder muscle imbalance. This is called scapular dyskinesis, where essentially the muscles in that patient are imbalanced, maybe they're weak, and they need to actually be strengthened in order to hold that scapula in place. Other times, shoulder instability can actually be a cause of this. If you have any kind of instability in the acromioclavicular joint out here, the sternoclavicular joint here, or even that ball and socket glenohumeral joint, any of those instabilities can actually throw off your shoulder blade so it's not moving in a smooth, normal pattern like it should. The thoraco-rib area, which is actually considered part of your shoulder, if there is any imbalance between the connection between the ribs and the shoulder blade moving over it, that can also lead to snapping scapula syndrome.
Yeah, I think, Danielle, you and I would agree that we're seeing this more and more. You know, like 10 years ago when we started working together, I mean, you would see it occasionally, but now because of computers and everybody's hunched over, and it's amazing, like, you know, I play golf. You know, what I'll do is when I'm playing golf, I'll look at everybody like in the other holes, and I'm just telling you, it's like everybody. Look at people walking down the street, you'll see that everybody's got this thing. So obviously there's going to be a problem right here, like where the thoracic spine is hunched over. And why physical therapy is helpful, but often not curative, is because it doesn't address, you know, the instabilities. Because basically, if you're hunched over all day, obviously there's going to be a massive strain to the ligament support of the, you know, thoracic spine and where it meets the ribs. And you and I have talked about where this is probably the major instability that we see with snapping scapula syndrome. I would just say also to people watching this is you can basically diagnose it yourself. Like, you know, like I got a pain here, and then you go like this and you can feel clicking, popping, grinding, crunching. So if that's you and you're like, man, there's a noise back there, then you basically have this thing. Then it's either you have to do something that's going to get you from this posture to this posture. That's what you were saying about muscle imbalances. So if you're like in this posture, it means that these things are too tight, these things are too elongated, and both of those can cause muscle weakness. Like if a tendon or muscle is too tight, or if a muscle is too elongated, it's not going to have the optimal power. So
I had a physical therapist explain this to me too before. Like, we're all in this hunched over posture. Like, you go to like a doctor's office, everybody in the waiting room on their cell phones, right? Like, that's just the society that we live in now, right? We're all hunched over. And what can happen is, like, these muscles up here, like let's say your upper traps, they're going to get so tight and they're really kind of taking the brunt of the work, so the lower part essentially gets shut off. That's how, that's in their words, you know.
That's true.
And so if you have that imbalance, not only one, can that affect your shoulder blade, right? Or two, it's just going to affect and alter the whole stresses on your spine and your shoulder in general, right? It can be very painful. This is a general picture of our vertebral column, right? So we have our cervical spine, our neck, our thoracic spine in the middle, and then our lumbar and sacral spine. I would say, and tell me if you agree, majority of the time when I see people that do have some kind of thoraco-rib instability, majority of the time it's up here. It's this upper part. Not that it couldn't be the mid-ribs or whatnot, but a lot of times it's these upper, you know, first rib, kind of the top third of that section really seems to be a big area where people are weak.
Yeah. The scapula basically goes from the top here till about T7. So the middle of the scapula would be like about T3, T4. But you're exactly right. When you're like this, it's almost always going to be there. And that's actually also where people feel a lot of the pain.
Yeah, like they get these like trigger points or kind of knots right up here on top of the shoulder blade. They feel like they have to work out. This is an example too. Like you can see, very obvious, like this shoulder blade is higher than this one. Like that person's kind of like slunked. It's not that everybody walks in looking like this, but it can be, you know, just with like improper muscle activation and instability to not hold it in place.
It's easy to understand too, if like when we say thoraco-rib instability, it's basically right here.
Yeah.
So imagine this segment right here is loose, so that you would have like a tender spot there, because often people say, I'm just telling you, man, it's hurting me right there. And then you can imagine if this is hunched over and there's a ligament problem here where the scapula is going to rub right there. And of course, we now have the technology in the office to show that, which is dynamic digital radiography or motion x-ray.
When we think about the shoulder, most of us just kind of think right here, right? But actually the shoulder is made up of 4 joints. So one is that ball and socket glenohumeral joint. Above it, the AC joint right here where that shoulder blade kind of wraps up and connects with your collarbone. The sternoclavicular joint where your collarbone attaches to your sternum. And then also back here, again, like we just pointed out on that last slide, where the ribs and the shoulder blade that lay over it. All of those joint articulations actually make up the shoulder. So again, very easy to see where instability in any of these can actually throw off or alter the normal movement of your scapula.
I would just say too, like, when you're hunched over like this, the ball of the shoulder joint, it goes forward, so that's where that's what causes the instability. Like we often think like, oh, you got to be a football player and get smashed, but if somebody's like this for 6 hours a day, 8 hours a day, and the strain on the ligaments that connect this bone to this bone are going to be too much, so then you get laxity. And you also know you would have laxity because you could just kind of do this and click, click, grind, grind, pop, pop. Well, if there's laxity here, that's obviously going to affect the scapula and again makes you more prone to snapping scapula syndrome.
One of the things that I've actually seen more recently, probably in the last year than I have before, is people that come in with a shoulder pain, shoulder blade pain, and you can just tell, like their shoulder, it's just like way round, compared to the other side, it's way too far rounded, and maybe that's the side that they write with, or are kind of more dominant or whatnot.
Oh, that's a good point. Yeah, that's true.
Which is oftentimes the case. And so a lot of times, like, well, you have to address all the joints, obviously, and they really have to work on that kind of posture and muscular support to bring it back.
Yeah, or that you move your mouse, like, I'm one of the people that was so right side dominant. I'm going boom, 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 boom for 30 years. I've been doing it with Prolotherapy. So I moved my mouse for that reason, so that's just a simple thing somebody could do. If you have it on the right side, move your mouse to the left side.
You touched on this before. People ask me a lot, like, how did this happen? Especially if somebody they weren't a football player or they didn't have a big accident. And what I say is people can get ligament laxity and instability from one of 2 ways, or maybe a combination of both. One is a big force in a short amount of time, like a car accident, you're tackled in football or whatnot. Or 2, a small force over a long period of time. So like if I am sitting with this bad posture on my phone, it's not that I'm putting a ton of strain or force on my tissues, but you do it 10 hours a day, 7 days a week, it adds up. In order for us to actually raise our arm over our head, yes, of course, our shoulder blade is going to move, but then also do our AC joint, again, shoulder blade, collarbone attachment, and then our sternoclavicular joint as well. They all actually really move as a unit.
I find with snapping scapula, like, you could just compare one arm to the other arm, and normally the one with snapping scapula just can't go as high. Because again, that's scapular dyskinesis, which means that you got crappy motion of your scapula. I mean, that's basically what it means. So the physical therapist, and you said to me earlier that almost all the patients that you see with snapping scapula, that you do recommend some physical therapy because
most of the time,
Prolotherapy can help with the ligaments, but because a lot of people we see, they've just been having it for years and years and years. So, you need a professional that can help you get that motion back to normal. We can help the instability and the pain. We help the pain
totally. Well, and most of us, if I just make a very blanket statement, most of us are really deconditioned, right? Like sometimes we need also too, like, yes, we have more stability from Prolo, but then let's kind of reteach ourselves how to keep these muscles balanced because we don't want anything to come back, right?
That's true.
So kind of to segue into this, I mean, there's a lot of muscles back here, right? A lot of layers of muscles that attach around the scapula that really help to support it and keep it stable as well.
Even your job or my job, you think, in healthcare field, we spend a reasonable amount of time each day on the computer.
For sure.
Like it's way more than, maybe people would think. Between researching, emails from me or the staff or from you, there's in an office, there's a lot of emails you got to get to. Then there's patient inquiries. Then there's all your notes.
Yep, charting.
And so I would just encourage people that when you're in front of the computer, you have got to be engaging your muscles, because the lazy thing to do, if we're all honest, is just to go like this. Like, in other words, let gravity just do this. But if if you have your computer high, you have to raise your chest so that this is a better posture for your scapula. And so again, using the computer can be a workout. We give exercise, and it's good to go to physical therapy, but maybe even more important, if you have a job that involves the computer, engage your muscles while you're using the computer.
Yeah, or even like I have a standing desk, so I'm not like hunched over. It's standing, ergonomically, so I don't have to slouch, which is really nice.
Yeah. Oh, yeah, that's a
yeah.
Good
This is perfect. So here, you can obviously tell on this side she's on her phone, which we're all on our phone, right? But see how like hunched over, especially at that cervical thoracic kind of neck thoracic junction that we were just talking about. Obviously this is a much better posture for her spine. Same thing with sitting down, looking at a computer or a phone, and then versus actually having it more upright. This is actually very interesting, something that I am more passionate about because this is in kids too. Most kids have tablets now, most kids are on cell phones or so forth at a young age. And so imagine if you're young and you spend a lot of time in this posture.
Well, when I was a kid, you had a TV, but you at least were looking straight at the TV. You weren't looking down at the TV. You're not saying not to have the tablets educate the kids, but you just gotta, if the kids are always looking down, it's not good. So it'd be better to have the kids watching something on an elevated TV so they have to look up.
What I do with my kids, and this is not what anybody has to do, but this is obviously something I'm a little bit more sensitive about seeing it in practice, is, they still like look on tablets or, we watch a lot of garbage truck videos on YouTube, right? And so I make them lay on their stomach so that when they're on the floor, they're not hunched over, they're kind of more propped with it on the floor.
Yeah, that's a good idea.
That's what I do at my house.
Well, when they're that way, then they use it, as long as they're using their neck muscles.
Yeah. So this actually is something that I wear. I don't have it on today, but I will actually wear this when I'm seeing patients because, again, I'm kind of hunched over a lot, and I'm working on my posture as well. This is a really good brace where you can see like it's bringing kind of shoulder blades back, not like an exaggerated way, but just enough to kind of get a little bit more muscle activation. Personally, when I have a thoracic pain, thoracic instability case, or even sometimes even with like this anterior shoulder instability, I put people in a brace at least temporarily while we're starting the healing process and trying to get those joints stable with prolotherapy. It's not forever. It's not a cure by any means. It's just a tool that I have that actually has helped me help my patients better while they're healing.
Well, it's also, somebody can do that at home.
For sure.
Because if that helps you, you either have some kind of instability or your posture's kind of bad. So it's diagnostic too.
Another thing that we haven't talked about yet or touched base on yet is when people have pain in this shoulder blade, top of the shoulder distribution. We talked about the shoulder, we talked about the thoracic, but it also could be a referral from the neck, right? Yeah, exactly. So like here, C4, C5, C6, C7, pain there could be referred from your neck.
Yeah, and that would be, again, somebody could be going to a physical therapist for some kind of scapular problem or some kind of shoulder problem, but it's actually a neck problem.
If you're doing this motion, you're like, I have pain here, I can feel it, but I don't have any clicking, I don't have any popping, like my shoulder doesn't pop, it doesn't, like my shoulder itself doesn't hurt, no clicking. That would be something where, if that's what the physical exam really confirms, like let's kind of travel up and see, all right, if your thoracic looks stable on motion x-ray and your scapula seems stable, let's see if this pain is actually coming from up above.
One of the things that somebody could do at home is the Diana Ross move, which is stop in the name of love. So in other words, if you go like this, it's kind of a cool thing.
I'm going to step out of the way, but I'm going to listen.
You know Diana Ross, right? Or she's before your time.
Yeah.
But this stretches these nerve roots. So this stretches these nerve roots. So in other words, I'm stretching the nerve roots. So my head's this way and I'm going like this. So if you do that and there's some kind of tingling or pain, especially if there's pain around here, that would be one sign that it's probably at least the neck's involved.
I've never heard that called the Diana Ross move. That's
like stop and then
I'm gonna stand over here. Yeah.
Stop in the name of love.
Okay, so we kind of talked about DDR, the dynamic imaging that we do here in the office, but we're actually going to show a video of it, which is really cool. So this is the patient's thoracic spine, okay? And then we have the ribs that are coming around, and then here is the shoulder blade, scapula, the humerus going down the arm. So if you just look like kind of at the patient's two different sides, you can see all the space here, right, between the shoulder blade and the ribs. And you lose that on this side. You don't actually have as much of that space there because you can see that scapula is rubbing on those ribs. So this is actually the patient's good side, which you'll see. Watch them kind of move.
You can see the space.
Yep. Which looks good.
Yep.
And then this is the bad side, or the symptomatic side, I should say.
The patient, they just don't have any, there's like no space there. Because somebody would be like, well, why are you doing both sides? I mean, you just got to see the difference. And for the patient, it's helpful because then you see the problem. When you see the problem, then you can do something about the problem. That's why in the office here, we just do a lot of diagnostics, and it's good for us. Then we've confirmed the diagnosis. Then for the patient, then after somebody's well, we normally wouldn't rescan them, but we could, and then you could see that it's resolved.
Same thing what we do with ultrasound. You know, when we ultrasound people's knees looking for medial instability, you see the symptomatic side, which gives you a lot of good data, but why not look at the asymptomatic? You know, what is really their good to not so good look like?
So you're saying from your perspective, this is mostly what you're doing prolotherapy for. So you're doing prolotherapy there and then...
For snapping scapula, yeah.
So it's mostly that.
Most of the time, yeah. In my experience, in my practice, it's mostly a thoraco-rib thing.
How many treatments typically do people need?
It also depends on several things, like how unstable it is and what their goals are, right? Are you trying to be an Ironman? Right. Or are you trying to, again, like sew without, having a lot of pain? But I will say this. I will say since I started like several years ago bracing more, it's actually been able to get us to actually get people better quicker, which is great. Awesome, right? Always the goal. Because the area is still under a lot of stress, like you're breathing all day, right? Like you're expanding your lungs and, putting strain on the ribs. I would say on average, it's about a 5 treatment series, kind of give or take.
Then why don't we just talk a little bit about that? So to optimize the healing after prolotherapy, if you can keep the ligaments in their shortest position, because imagine you're doing prolotherapy, but yet the person's hunched over the computer, then you're stretching the ligaments. But if because some people might see this and say, yeah, but you're going to get the muscles all weak, because you're doing a brace. But the person's getting a medical procedure, and you have to try to keep the ligaments in their shortest position. So most of us can't all day, right? And then even with a brace, you still can use your computer and use the muscles. It's not like the brace doesn't allow you to use your muscles. So the brace allows you to keep the ligaments in the shortest position. And then when you're working or exercising, you're engaging the muscles. So you're getting, you're doing everything to optimize the healing from the prolo.
Well, and it depends too. Like, let's say I have a patient who's on their computer all the time. Like, I'm going to have them wear this brace more than somebody who isn't in that profession, But let's say I have someone who takes pretty good care of themselves, but they always overdo it. They're like, oh, if I'm playing pickleball, I'm going like 100% of the time. I'm not going to play at 50%. Well, then I'm going to put you in this because it's going to remind you not to. Like it just kind of, there's a couple ways you can look at it. But again, this is not something patients wear 24/7. It's not something that they wear for the rest of their life. It's just to help get these ligaments tight, allow you then, when you have joint instability, to be more efficient at building muscle, once those underlying joints are stable, and then, take the brace off. Pack it away, throw it in a fire, whatever you want to do, you're done with it when you get to the stability.